So today, let's take a look at what's happening in osteoporosis. I'm Dr. Veronica Piziak, and I am an endocrinologist at Baylor Scott & White. And if you have questions, you could send them to vpiziak@sw.org. I have no disclosures for this topic, and there's no discussion of unapproved medications. We are going to discuss who to screen for osteoporosis, how to screen, who and how to treat, how long to treat, problems with therapy, and a little bit about Romosozumab, which is now approved by the FDA for osteoporosis. It's the new osteoporosis drug. Okay, first of all, let's take a look at how women accrue bone. They accrue calcium over the course of the first 14 years of life, so that by the time a woman is age 14, she has about 95% of her mother's peak bone mass. And it's your peak bone mass at about 20 to 25 that keeps you from fracturing your hip at age 100. So the first thing we want to do with our patients is to get calcium, exercise, and nutrition on board, and make sure they have adequate vitamin D in their adolescence. So those of you who take care of teenagers, remember, want to get those on board so that we can maximize the peak bone mass. At menopause, unfortunately, women can lose about a third of their bone mass, and some of them have a rapid bone loss around menopause. How can we help that? By giving adequate calcium. 1,200 milligrams of elemental calcium a day decreases the rate at which a woman loses bone at menopause. We can also use hormone therapy, selective estrogen receptor modulators, or bisphosphonates to stop the loss of bone mass at menopause. About 8 years after menopause, there's a gradual bone mass loss. And again, that is very likely to be prevented by using calcium, vitamin D, and exercise. Walking is very good exercise. We'll talk about that in a bit. Finally, as we get into our 8th and 9th decade, we begin to not synthesize bone as well. And when we have people who are menopausal at that age, calcium and vitamin D are still helpful. We can use bone stimulators to help prevent the bone mass loss to an extent. But the real key here in that last block is fall prevention. So be sure you discuss fall prevention with your patients. So we're going to prevent fracture by maximizing peak bone mass, which can be accrued in women up to age 25, by stopping the acceleration of bone mass at the menopause, and by watching the age-related bone mass and giving calcium and vitamin D as we go down the bone mass hill. And finally, fall prevention, very important. But calcium, vitamin D, or nutrition are important there as well. And prevention of loss of muscle mass in our older patients in their 60s to 80s and 90s is very important as well. And that's done with exercise. But fall prevention, again, is the key in this group of patients. How about men? Well, osteoporosis doesn't occur as often as in men, mainly because they have a higher peak bone mass and they don't lose testosterone. So they keep their testosterone for their lifetime for the most part. And as a result, they lose muscle mass as they get older, and the bone mass is correlated with muscle mass loss. So if your patient keeps his testosterone, exercises so that he doesn't lose muscle mass, his bone mass is very well preserved. Men also need calcium and vitamin D at all of the phases in their lives, and they also need 1,200 milligrams of elemental calcium and about 800 to 1,000 international units of vitamin D3. Again, we can use bone stimulators, we can use anti-resorptive agents in men, but they get osteoporosis less often. Testosterone loss accelerates bone loss. And if a man loses his testosterone, then his bone mass loss parallels that of a woman at the menopause. All right, let's take a look at the definition of osteoporosis. It's a skeletal disorder characterized by excessive bone-destroying cells, or osteoclast-mediated bone resorption, and poor repair. But Remember, very important, there's a normal mineral to matrix ratio here. These are thin bones, but they are well mineralized bones with normal matrices. So osteoporosis has normal bone, just less of it. And our most commonly used bone active agents, the bisphosphonates, reestablish bone by inhibiting bone destruction more than they inhibit bone building. Unfortunately, they also can inhibit bone building. And so eventually, the bisphosphonates suppress bone building, and then we can get atraumatic fractures that we will discuss under side effects of bisphosphonates. But early on, for at least 1 to 4 years, they are very safe. Okay, let's look at who to screen. Women age 65 or older, according to the National Osteoporosis Foundation. Any woman 65 years of age with a fracture, the NCQA says we must screen those people. Postmenopausal women at risk for fracture, if they have risk factors in addition to menopause. And most insurance companies will pay for you to screen any postmenopausal woman. Men aged 70 or older should be screened according to the National Osteoporosis Foundation and the Endocrine Society. People between 50 and 69 who are at risk, that's the people with rheumatoid arthritis, the patients who have on steroid medication for more than 3 months or injectable steroids for 3 or more times a year, patients with malabsorption, celiac disease, gastric bypass patients, and anyone with a fragility fracture at age 50 or older needs to be screened for osteoporosis. And new indications in 2020, anyone with diabetes or sleep apnea. How to screen? The DEXA scan is widely used in the United States and is our best screening tool. It's inexpensive. It tells us about bone mineral density. The DEXA scan makes the diagnosis. It tells us how much bone the patient has lost, where their bone is now. You're going to look at the picture of the DEXA if you can and use the lowest T-score to decide the diagnosis. It also monitors the effectiveness of therapy, and to do that, we can get a DEXA scan every 1 to 3 years. Medicare pays every 2 years, and that's a reasonable amount of time to repeat the DEXA scan. It also compares the bone mineral densities, and you want to do that. If you want to know whether Mrs. Schmedlab has lost bone over the last 2 years, you compare the bone mineral densities for those 2 years, not the T-scores. The T-score is a surrogate marker, and so you are going to want to compare bone mineral densities. Very important. I get a lot of consults where people say, my patient has lost from a T-score of minus 1.8 to minus 2.1. What should I do? What you should do is compare the loss of bone mineral densities. Again, do not use the T-scores to determine bone mineral density loss. You can also predict fracture with the DEXA scan, but it's not as effective as FRAX. And so we're going to talk about using FRAX instead. Now let's take a look at this picture of a spine. The spine should be straight. The DEXA looks at L1 through L4. And you're going to look to make the diagnosis at the T-score. And the T-score is the number of standard deviations. Those are the big blocks here. This is the young adult mean, and the patient's T-score is the number of standard deviations above or below the young adult mean. And so that's what makes the diagnosis. Unfortunately, many of our patients have spines that look like this, and so we're not going to be able to tell much from this spine. We know the patient has osteoporosis because the T-scores are all less than 2.5, 2.5, minus 3.7, minus 4.8. So she has osteoporosis, but we couldn't tell from 1 year to another whether or not she had any changes because we're not going to be able to reproduce exactly this really poor DEXA. So in general, patients whose DEXA scans look like this in the spine, you can't interpret them, and you must use the hip. In fact, in patients over the age of 60, using the hip to determine your diagnosis and your changes are going to be the most accurate way of doing it. And this is a hip in proper position. You can see the femoral neck box is on the femoral neck. The pelvis and the femur are at a 45-degree angle, and the femur is straight up and down. Okay, so let's take a look at osteoporosis and the WHO diagnostic criteria for osteoporosis. The World Health Organization said that osteoporosis is a T-score of -2.5 and below, that -1 to -2.5 is osteopenia, and down to -1 T-score is normal. So that gives us the basis for diagnosis. But remember, the DEXA doesn't do some things. It doesn't measure bone strength, and it doesn't tell us about bone matrix problems. We said osteoporosis has a normal mineral to matrix ratio. So it underestimates the risk in patients, for example, who have diabetes, who have matrix problems, but not mineralization problems. It doesn't distinguish between diseases. The patient with vitamin D deficiency can have osteoporosis or osteopenia. But remember that the patient with vitamin D deficiency does not have a normal mineral to matrix ratio. So it doesn't tell us which disease we have or whether we have a normal mineral to matrix ratio. It only tells us about bone mineral density. So once we have these things in mind, the DEX is really an important tool to use. Okay, now let's look at who to treat. This is an updated NOF clinician's guide, and it tells us we need to initiate treatment in postmenopausal women and men who are equal to or over the age of 50 with a hip or vertebral fracture. Those patients, by definition, have osteoporosis no matter what the DEXA shows, no matter what the T-score is. They have osteoporosis because they have had a fragility fracture, which is they have broken a hip by falling from a standing height. They've broken a vertebra by lifting something that we would ordinarily assume a normal person would be able to lift, for example. In addition to that, if you have a low bone mass and a 10-year hip fracture probability on FRAX of greater than or equal to 3%, or a 10-year major osteoporotic related fracture probability of equal to or greater than 20%, you should be treated. And it doesn't really matter what your T-score is or whether or not you've had fractures. If you have other prior fracture and a low bone mass or a T-score lower than 2.5, and most people would treat the 2.5, but there's some guidelines that say lower than 2.5. Also, a low bone mass and a secondary cause with a high risk of fracture. That would be your patients on steroids mainly, or perhaps your patients with significant vitamin D deficiency. So again, um, these are the criteria for who to treat without a DEXA scan. You may get one to determine the baseline bone mineral density. Certainly it's allowed, but you're going to treat these people. Okay, our goal is to prevent fractures in patients with significant risk. And only 23% of the patients with hip fractures are treated on discharge from the hospital. That is a very sad statistic from 2020, not from the 1900s. So again, we're still not treating these people when they fracture their hip. So remember, you do that in your clinical practice. Okay, who has the most fractures and how did we decide on -2.5? If you look at the bone distribution, the people in yellow, that's the fracture rate. So the number of women with fractures over here with T-scores of -2.5, -3, -3.5, the numbers are small because the population is small. But look at the fracture rate in yellow in these people. They have a very high fracture rate. And that's the reason they decided on -2.5 for therapy, because you can see the fracture rate really changes quite a bit between -2.5 and -2. So -2.5, you bought yourself some therapy for osteoporosis. But look at the large number of fractures, the number of women with fractures. My goodness, that doesn't peak at -2.5. That's between -1 and -2. So which of these people with the light blue lines are we going to treat? And that's where FRAX comes in. It tells us who, with osteopenia, we are going to treat. And remember that FRAX is simply our risk factors that we know about: alcohol, steroids, family history, and so on. And They are weighted, and there's a giant database that was compiled to look at the fracture rate in people with certain risk factors. And that was what FRAX was derived from. So, major osteoporotic risk 20%, hip fracture risk 3% over the next 10 years. So, this allows you to calculate the probability that your patient will have a fracture over the next 10 years using their risk factors. And it allows you to decide who to treat. So, you're going to treat patients, major osteoporotic fracture risk of 20%, and hip fracture risk of 3% over the next 10 years. If they're under that, then you and the patient can decide whether or not you wish to treat them, but there's not an indication at that point. Are there problems with FRAX? You bet. It's excellent for women 60 plus who have osteopenia. Works beautifully. However, it underestimates the risk for early postmenopausal women, so adding the hip bone mineral density calculation to the FRAX helps that. Remember, FRAX does not need a DEXA scan or bone mineral density to use it, but it is a little more accurate if you do have a bone mineral density. It's not accurate if the patient's been on bone active agents because remember, that's what we're treating. We're treating to remove the risk factors with our bone active agent. We are overcoming the risk factors. So it's not very accurate to tell us how we're doing while the patient's on the bisphosphonate or on your denosumab, on your therapies. However, there's a lot of question about is it accurate after a drug holiday? Can we use the FRAX to tell us when patients can get back on their medication when they need to be treated again after a drug holiday? It obviously doesn't address falls, and it underestimates type 2 diabetes. But they have done some statistical analyses, and in your patients with type 2 diabetes, if you click the rheumatoid arthritis button on FRAX, as you can see here, it's down at the bottom, and even if the patient doesn't have rheumatoid arthritis, but they have diabetes, click the rheumatoid arthritis box, and it will help you. The other thing you can do is to lower the T-score by 0.5% as you're using it in the FRAX. Or if your patient had a T-score of -2 and you lower it by 0.5%, then you're going to treat because they're -2.5. The higher the hemoglobin A1C, the higher the fracture risk. And that was just discovered in the bone meeting in September of 2020. So that's a new fact that we ought to remember in our patients with diabetes because we glycosylate the bone matrix. And when it's glycosylated, it is weaker. Okay, how to treat. Let's talk about calcium and vitamin D. And together, they decrease the hip and non-vertebral fracture risk significantly. That was found by a meta-analysis published in the Journal of Clinical Endocrinology and Metabolism in 2019. So the question of should we use calcium and vitamin D because they prevent fractures? Yes, they do prevent fractures. Exercise decreases bone mass loss, and fall prevention decreases fractures. Okay, how much calcium? Recommendations to the National Academy of Science, again, men and women, any age, 1,000 to 2,000 milligrams a day. Dietary calcium is best. How much vitamin D? Recommendations from National Academy of Sciences, 6,000 international units a day for everyone under age 71, 800 international units for people over age 71, and many people, including the National Osteoporosis Foundation, feel that those recommendations are too low. So back to the beginning when we said 1,000 international units is a very good compromise for your patients. And generally, the calcium tablets that they take, if they take 1,200 milligrams a day, will contain 800 to 1,000 international units of vitamin D. More than 4,000 international units of vitamin D is not recommended by the USDA and can lead to vitamin D toxicity. Interestingly, we've been seeing some vitamin D toxicity because people are now taking vitamin D to prevent COVID. And so as a result, they're getting a little toxic. Remember that it looks as though the majority of people who have COVID had vitamin D deficiency or insufficiency, but there's no data to show that taking extra vitamin D is going to help prevent developing the viral infection. Who to screen for vitamin D deficiency? Obviously, people who don't get in the sun, like the institutionalized elderly, breastfed infants. If you're breastfeeding, unless you take a lot of vitamin D, if your mom and you're breastfeeding, vitamin D is poorly transferred in the breast milk. Rapid bone turnover states, hyperthyroidism, patients who are losing bone for any reason, patients on steroids need to be on vitamin D. Patients who have osteoporosis or osteopenia. And you say, uh-oh, how am I going to code for my vitamin D screen? R79.89 is a very potent code that will pay for most vitamin D tests. How to replace vitamin D? Well, we measure 25-hydroxy vitamin D. Remember, it is the most stable metabolite, and it gives us an idea of the liver stores, and that should be between 30 and 40 nanograms per mil, because that is the goal. So the goal, 30 nanograms per mil, and about 1,000 IUs of D3 a day. If you're just close to that, you're in the 16 to 20 range, 1,000 of D3 a day should do it. But if you have significant deficiency, particularly if your 25D is 10 or less, we are going to need to treat you with heavy duty vitamin D. And for a long time, that has been 50,000 international units of vitamin D2 once a week for 8 to 12 weeks, or until the patient is replete. Sometimes it takes a lot longer than 8 to 12 weeks. If you start out with a vitamin D of 4, or you're very obese, we may take months to replete you, so don't give up. You may also use D3 4,000 international units a day if that is less expensive for your patient than paying for the 50,000 international unit D2 tablets. You want to check the 25-hydroxy vitamin D at about 12 weeks after you've been replacing to see where you are. And remember that, again, vitamin D is a fat-soluble vitamin. So a 20 to 30 range requires about 50 international units per kilogram per day. If your patient weighs 300 pounds, 50,000 international units of D2 once a week isn't going to be anywhere near replacement, and is barely a sustenance level for those people. So you might want to give them extra vitamin D if their BMI is high. How about exercise in the older population? There's been a nice randomized prospective control study that looked at targeted exercise and vitamin D to reduce falls in 70 to 80-year-old women. There are 4 groups: the exercise plus D group, the exercise no D, no exercise plus D, and no exercise and no D. And they looked at the endpoint as falls, and particularly injurious falls. And they were able to show that although the fall rate was the same, the injuries were statistically significantly lower in the people who had adequate vitamin D. So vitamin D helps decrease the injurious falls. So, but that's vitamin D sufficiency. Again, that's not necessarily extra vitamin D. So vitamin D is important. But exercise plus D gave us the very best statistically significant decrease in fracture. Bone remodeling. Let's take a look at what we're treating. The osteoclast comes by in response to microfractures of the bone. The microscopic dents and cracks that we get as we move around cause us to remodel. And when the osteoclasts come by, they liberate growth factors which stimulate the proliferation of osteoblasts, which are the bone building cells. And the bone building cells then fill in the niches made by the osteoclasts. So in order to remodel bone, you have to have active osteoclasts. And so if they're suppressed by bisphosphonate, after a time, you don't remodel bone, and then the fracture rate goes up. In order to build bone, you have to have calcium, phosphorus, and active vitamin D, which is 1,25-dihydroxy vitamin D. We inhibit osteoclasts with bisphosphonate. The bisphosphonate stays in the bone, and when the osteoclasts destroy the bone, the bisphosphonate is taken up into the osteoclast and inhibits its production of cholesterol, which stops it from sealing over the bone and also makes its life shorter. We can stimulate the osteoblasts with Teriparatide and Abaloparatide and Romosozumab in our armamentarium of medications, and they stimulate the osteoblasts directly. This is a micrograph of an osteoclast-mediated bone resorption. No matter how old you are or how many problems you have, the osteoclast digs the same size hole every single time. The problem is that with aging, we don't fill those holes quite so well. Particularly, we have fewer osteoblasts and they don't work as well. So, how are we going to treat using our knowledge about bone remodeling? First, make sure you're treating osteoporosis and not another bone disease, such as osteomalacia or renal bone disease. So before you treat, you need to know the calcium, the 25-hydroxy vitamin D level, and you need to make them normal. You need to know the creatinine, the estimated glomerular filtration rate, because up down to a CKD level of 3A, an estimated glomerular filtration rate of 45 or better, you are treating osteoporosis. Below at 3B, chronic renal disease, and below, you are also treating metabolic bone disease from the renal disease, and bisphosphonates and our bone stimulators may not work at those levels very well. You also need to make sure the patient has adequate dietary calcium intake. That is really the best way to get your calcium in. Okay, how to treat? Well, let's take a look at the approved medications. We said the anti-resorptive agents act primarily on osteoclasts to inhibit them. So that would be bisphosphonates, denosumab, raloxifene, and calcitonin. The anabolic agents, the abaloparatide and teriparatide, that would be Forteo and Tymlos, actually stimulate osteoblasts. Calcitonin should be wiped out of your armamentarium because it increases the risk of liver malignancy, and the FDA says you must discuss that with your patients. Raloxifene, calcitonin, and abandonate do not decrease hip fracture. The abaloparatide and teriparatide, the Forteo and Tymlos, do not decrease the risk of hip fracture, but do decrease the risk of non-vertebral fractures. Alendronate is the oldest bisphosphonate that we have in the United States, and it has been around for many years. It still works. It's still the most commonly used therapy for osteoporosis, and it is generic, so it's inexpensive. It has a long half-life in bones. It is most associated with atraumatic subtrochanteric hip fractures, and there are some limitations of use. The optimal duration of use, the FDA says, has not been determined, but for patients at low risk for fracture, you want to consider drug discontinuation after 3 to 5 years of use. And there is some new data suggesting that 3 to 5 years is reasonably safe, except for Asian patients. And in those patients, you probably want to stop at about 3 to 4 years. Okay, Resorption is marketed as Actonel, and that's 150 milligrams once a month. It's also approved for a therapy of osteoporosis. Abandonate, likewise, 150 milligrams a month, and a minimum of 60-minute wait rather than 30-minute wait before eating. It's available in IV as well, but neither of these are quite as effective or as accessible or as inexpensive as alendronate. Zoledronic acid is our most potent bisphosphonate. It's once a year IV therapy, and it is approved for steroid-induced osteoporosis as well as male and female osteoporosis. It's a 15-minute infusion, and I'd urge you to look into that because it works for a number of your patients, but it has side effects. You have to be very careful that the calcium is normal when you give this. If you want to avoid hypocalcemia, which can result in seizures, you need to make sure that the 25-hydroxy vitamin D is at least 25, if not 30, because otherwise you can develop severe bone pain when giving this medication. It's generic, but it's expensive. And 3 to 5 years use is what's recommended. Most people are using it around 3 years if they can possibly just switch over after that. Okay, Raloxifene or Evista. Remember, benefits are lost quickly. There's no bone suppression, however, and it is approved for the therapy of postmenopausal osteoporosis. There's no fracture risk reduction seen in the hip and non-vertebral fractures. So again, works in the spine, has few side effects, and the benefits are lost quickly when you stop it. So you must follow it with something like denosumab or the bisphosphonates to prevent the loss of bone mineral density. Denosumab or Prolia is indicated for postmenopausal osteoporosis, male osteoporosis, and has been used extensively also in steroid-induced osteoporosis to protect the bones. It's indicated with a high risk of fracture. It has a few more side effects than the bisphosphonates, but you may use it in renal insufficiency. And we know that through stage 3A CKD, it prevents fractures. You must monitor the calcium carefully because patients can develop severe hypocalcemia on this medication. So be sure you know that they're taking their calcium and that their calcium level is normal. There's 10 years of data. We know that it continues to reduce fractures and it does not produce bone suppression. So that's very helpful. Side effects, significant. You can develop more UTIs, skin infections, pancreatitis, dermatitis. Rash would be the most common side effect. It is rarely involved with osteonecrosis of the jaw, or atraumatic fractures, but can be, and particularly in your patients who have dental procedures or particularly dental implants, you do not want them to be on this at that time. But you can wait 6 months. After the 6-month time period, remember, denosumab is gone. And so you may then do your implant and then resume again. Okay, here's a question for you. Your patient on denosumab has missed her follow-up appointment 2 weeks ago. You contact her and say, 1, don't worry, take your calcium and vitamin D and reschedule when you can. 2, you need to come in during the next 4 weeks. 3, start zoledronic acid in 2 or 3 months. And 4, your COVID-19 risk will go down and you'll slowly lose bone. Well, it's number 2. You really need to get your denosumab injections on time. If treatment is delayed more than 6 weeks after the 6-month period, bone loss and increased fractures may occur. You need to, if you're going to stop the denosumab, follow with about a year of bisphosphonate or raloxifene. Zoledronic acid has been shown to preserve bone mineral density for 2 years if given right at the time the denosumab ends. So at the end of the 6-month interval, if you're going to switch off denosumab, that's the time to start the bisphosphonate. Zoledronic acid works very nicely. Alendronate will work. So again, switching off, you must do something to preserve the bone mineral density. So bisphosphonate or raloxifene. There's no increased risk of viral infections with denosumab. So you don't have to worry about COVID-19 increasing in your patients taking denosumab, and you can give flu vaccine the same day as denosumab without any problems. Serious side effects. Let's take a look at atraumatic subtrochanteric fractures for just a few minutes. Most of the data on this and also in osteonecrosis of the jaw is with alendronate because most of the patients were treated with alendronate for the longest number of years. It's potentially a problem with anything that inhibits osteoclasts. Risk of atypical fracture. Again, 200,000 women were followed, and there were 277 atypical fractures. They were followed for 10 years, usually on alendronate. Who developed fractures? Asians, patients who were of higher weight, patients who were on steroids. Again, duration of use for 10,000 women, less than 3 years, absolutely no risk. 3 years, 2 in 10,000. 5 years, 8 in 10,000. And 10 years, 38 in 10,000. So your patients who are Asian, you're probably going to want to think about using for, 3 years, maybe 5, but most people safe for 5 years. And then we probably ought to think of using something else. When you've discontinued the bisphosphonate for 15 months, the risk of atypical fracture is back to baseline. So you can take a drug holiday for 15 months if the patient is eligible for that, and then you can use the bisphosphonate again. So it's not that it's eliminated for all time, it's just eliminated for 15 months until the bone turnover starts again. Does everybody get some bone suppression? Yes, this is data from the zoledronic acid trial, and it shows that by month 36, everyone had an average of 29% reduction in bone formation. So again, it's going to be everybody who is on a bisphosphonate. Asians apparently have more problems than the other ethnic groups. Zoledronic acid has about a 3-year life in bone, but the duration, some studies have now shown, is 18 months. And so it's off label, but a number of people are beginning to use it at 18 months so that they can get an extra number of zoledronic acid infusions over a 5-year time period. But the actually FDA indication and FDA duration is osteoporosis and or elevated FRAX and once a year. Okay, what about who is going to have the most problems? Well, we said Asians are going to have the most problems with atypical fractures. We knew that. And they also get atypical radial fractures, we found out. But what is our clue that the patient is going to be having a problem? Dull, achy pain in the groin or thigh occurs in 70% of people who are going to have an atraumatic subtrochanteric fracture. Comorbid conditions such as vitamin D deficiency, rheumatoid arthritis, diabetes, and obesity in Asian ethnic group also predispose people. And of course, the use of bisphosphonates and steroids. These are frequently bilateral fractures if we let them go on, and they have delayed healing. That's what the fracture looks like. And it fractures right along this line where the stress fracture occurs. These are stress fractures, and you can see the periosteal changes, the little fractures in the cortex, and it fractures again right along this line. When to start a drug holiday? Well, there's not very much data, and the best data is from the FDA study in 2012, and that was mostly on alendronate. If a woman has had no prevalent vertebral fractures before you started it, then and she no longer has osteoporosis, then you can stop. If she has osteoporosis, so her T-score is below or equal to -2.5, then you need to continue. Women who had a fracture before you started, you need to treat those who still have osteoporosis and those who have a T-score of -2 to -2.5. If their T-score is above -2, then you can stop and take a drug holiday. So if you continue, then you must reevaluate again every 3 to 5 years. And with the new medication we have, the new medications that we have, and also our new data on the reason for subtrochanteric atraumatic fractures and our new data on when they occur in certain and high risk groups, we need to really decide that 3 to 5 years is going to be how long we're going to use the bisphosphonate, and then we really need to either switch or take a drug holiday. When is the holiday over? You're going to get a DEXA scan in 2 years, and if there's a significant decrease in bone mineral density, then you can restart the medication. Remember, after 15 months, you can restart the bisphosphonate. You can also use bone destruction markers, and more insurance companies are covering those. And serum N-telopeptide, remember, is a molecular piece of the protein matrix of bone that occurs, rises in the bloodstream when you have increased bone turnover. So you could use those to see if your holiday is over as well. How about ONJ? Well, it's very rare. So osteonecrosis of the bone, extremely rare, diagnosed by cone beam CT or MRI. If so, you have a patient that has a discrepancy that looks like their jaw is having a problem, you can actually get one of those radiographs, and it will show you what's going on. As you can see in the left-hand picture, you might miss this little dent in the jaw. But as you progress along here, you certainly wouldn't miss the necrotic area in the jaw. So even looking in the mouth will be helpful. And the necrotic area correlates with that radiograph on your far right. So for ONJ, it's not the duration of therapy, has nothing to do with that. It's prevention with good oral hygiene. If the patient has good oral hygiene, if they don't have a lot of cavities before they begin, if they have dental disease, fix it before they begin their osteoporosis therapy. For patients at high risk, you want to stop the anti-resorptive agents following extensive dental surgery, but that is extractions, that is implants. You want to make sure those sites are healed. And so the Dental Association agrees that good oral hygiene is the best thing to do to prevent ONJ. Okay, as we finish, let's talk for a few minutes about the anabolic agents, Teriparatide, Forteo, Abaloparatide, Tymlos, and Romosozumab. Those are approved for osteoporosis. They directly stimulate osteoblasts, and the Abaloparatide and the Teriparatide come in a metered dose pen. The Teriparatide has been shown to decrease spinal fractures and non-vertebral fractures, but not hip fractures, and is approved for 2 years of use. You need to follow this with a bisphosphonate or denosumab because you're going to lose the bone gradually over the course of the next 2 years if you do not cement it in place with an anti-resorptive agent. Abaloparatide, Tymlos, is PTHrP 134 analog, very similar to teriparatide, and it's approved again for postmenopausal women with osteoporosis, particularly with osteoporotic fracture, particularly with vertebral fracture. It reduces the risk of vertebral fractures and non-vertebral fractures, but again, not hip fractures. It's only approved for 2 years of use, and you need to follow with alendronate, and that will give you an enhanced effect, just as it does with teriparatide or Forteo. Why was this developed? It was developed at a lower cost, so it costs less than teriparatide. When to use these: severe osteoporosis, T-score of -3 with previous fractures, particularly people with multiple spinal fractures. It works very nicely to help them build bone in the spine. There are a few side effects, but these drugs are considerably more expensive than the others we've discussed. Side effects for both: they can cause orthostatic hypotension, but rarely do. Hypercalcemia can occur, and that is more common. So be sure you monitor the calcium once you started these people on the medications. Hypercalciuria. If these patients have any risk factors for hypercalciuria, you want to make sure you measure. For example, if they are on steroids and have hypercalciuria, you have to watch for symptoms of renal stones. And they're both limited to 2 years due to osteosarcoma in the rat. However, the teriparatide study after 15 years has shown no increased activity, no increased osteosarcoma in the human after the 2-year period. So this is a 15-year study, no osteosarcoma in the human after 2 years of teriparatide. Romosozumab is the newest agent on the market. It's both an anabolic agent and an anti-resorptive agent, and it must be followed by an anti-resorptive agent. It's indicated for high-risk women with fragility fractures or those not able to tolerate other agents. It has the same side effects, but also can cause headaches, and there's a black box warning because the treated group had a higher incidence of myocardial infarction and stroke. And so you should not use this in patients who have had a myocardial infarction or a stroke in the last year, because it may increase the risk of myocardial infarction, stroke, and cardiovascular death. Okay, in summary, we're going to look at the DEXA picture. We're going to get the T-score for diagnosis, the bone density for serial changes. We're going to treat osteoporosis, T-score -2.5 or lower, or high-risk osteopenia using the FRAX to determine that category. Therapy, 3 to 5 years for bisphosphonates is a safe window for Asians. You want to maybe shave that window off a little bit. You can stop it if there are no fractures and the T-score is above -2.5, or fractures and the T-score is above -2. Taking a drug holiday. When's the holiday over? A fracture or significant decrease in BMD or an increased N-telopeptide. Denosumab, up to 10 years of use, but you can't take a drug holiday without cementing the bone in place with an anti-resorptive agent such as a bisphosphonate or Raloxifene. Romosozumab is an anabolic agent used for a year in high-risk patients, but it must be followed by an anti-resorptive agent. Thank you very much for participating in this discussion.